I think without wasting any time, we must start this session well. And we are dealing with the topic which is because we are not satisfied with whatever technique we follow for the trabeculectomy and its modifications. And there is something else beyond trabeculectomy. And I'll request Dr. Bineta, who is in All India Institute of Medical Sciences in the 6th branch. They're all working in the glaucoma for so many years now. So I'll request Dr. Bineta to decode the intricacies of the trabeculectomy. Dr. Bineta, please.
Thank you, sir. So without wasting much of time, I'll start with my talk itself. In a developing country like ours, where most of the patients are coming in the advanced stage of the disease, getting the pressures to low teens is what we require, and so obviously a trabeculectomy plays an important role. And I'll be talking about the small steps which you should be considering while doing your primary trabeculectomy so as to have enhanced success of your trabeculectomy. As we all know, obviously this term was coined by Sugar and propagated by Kahns to describe a partial thickness fistula which is created between the anterior chamber and your subconjunctival space. But before we start doing a surgery, take the patient to the operating room, it is important that obviously all these patients are on anti-glaucoma medications for a long time. So it is important that you should stop alpha agonists, which are known to cause more of a fibrosis of the bleb, discontinue myotics. Beta blockers also, if the patient is on the beta blockers, which is a commonly used drug in our country, you should stop them one night before the surgery. And it has been studied in various studies that because of the long use of these anti-glaucoma drugs, the fibrosis which has been induced as a result of that, if you give low-potency steroids starting maybe preferably 1 month before or maybe even 2 weeks before, it helps in reversing the histological changes which have happened in the conjunctiva as a result of that. At the time of surgery, obviously giving a bolus of mannitol to lower the IOP so that we can do a safe entry into the anterior chamber. And as regards to anesthesia which is required, you can use a general anesthesia. Obviously in those cases, mannitol dosage would vary because GA itself causes a lowering of the mannitol, lowering of the intraocular pressure. But if you're using a peribulbar or retrobulbar block, please ensure that you're using a very minimal amount of block so that you do not want intraoperative rise of IOP or a tight globe. And if you're using a subconjunctival subtenous block, ensure that you're using a 30 gauge needle, a very small needle, and you're injecting at the same site without causing any subconjunctival hemorrhage at the site of your incision of the conjunctiva. So just a broad overview, like I'm just revisiting the steps. So first, obviously you're putting a traction suture to give you a good exposure, followed by, can I have a pointer please? So you're just giving a broad exposure to get a wide exposure, you're using a traction suture, followed by a conjunctival flap creation, which could be a limbal based or a phonics based flap, followed by a scleral flap, which could be of any shape, a triangular, a rectangular, or trapezoid shape. And then the application of an antimetabolite, which is very important in these days, especially unless until you have some contraindications to it. Unless you have some contraindications to it, you can use mitomycin C sponges, or you can even inject it before making your conjunctivals flap. And you can use it either subconjunctivally, or some people prefer to use based on their individual preference, both subconjunctival and subsclerally. And then obviously, this step is very important because you want an intraoperative titration of your aqueous drainage. So obviously creation of a paracentesis. Then you can create, either you can create your, then you create your full thickness in a sclerostomy and followed by peripheral iridectomy. And finally is the closure of your flaps, the scleral flaps and the conjunctival flap, which you want, in the end, what you want is a watertight closure. So just now to go, what are the steps you should be observing on each step is like, the first thing is to have a good exposure. So whenever you are applying your speculum, it is important that there should be no drag. Okay, sorry. There should be no drag on the globe. There should be no drag on the globe when you are, or no drag on the conjunctiva, and no pressure on the globe when you are applying your speculum. Next thing is applying a traction suture. Earlier when we were doing more of limbal-based flaps, we were using superior suture, but nowadays the trend has shifted towards phonics-based flaps. Obviously a traction suture on a cornea is much better. It gives you a firmer traction. It gives you no damage to the conjunctiva or any risk of subconjunctival hemorrhage and no risk of postoperative ptosis, which could have happened with a superior suture. Remember to take a deep bite because you do not want a cut-through suture at that time. So you can even increase your magnification. You do not want tunneling also. You do not want to have corneal perforations also. Next is your flap. As I told you, it depends on the individual preference. You can use limbal-based or a phonics-based flaps, but nowadays, obviously, a phonics-based flap is being preferred because obviously it gives you a faster and easier, better exposure. Any revisions are easier, then applying releasable sutures is easier, and obviously it gives you a more diffuse bleb. What is the minimum? You should have at least 6 to 7 meters of exposure, as I'm showing in this video, and remove any loose or any extra tissue which is there, episcleral tissue, but avoid any buttonholing. So you have to be very gentle while handling the conjunctiva. And while using cautery also, you have to be very gentle. Cauterize only the episcleral vessels. You do not want to do unnecessary cauterization, which can lead to shrinkage of your scleral flap. Next is the application of antimetabolites. Obviously, it is recommended in most of the cases. Exceptions may be a very ophthalmic eye, very, very thin sclera. Otherwise, you use motamycin depending on the dosage, which may vary, could be tailor-made to individual cases. Use multiple sponges because this gives a wider bleb, a wider area of coverage, and you avoid touching conjunctival wound edges at all times. And in certain cases now, people are even preferring to use, give injectable subconjunctival, inject subconjunctival mitomycin before doing your conjunctival resection. As regards to scleral flap, obviously you do not again want very thin flaps because they will lead to overfiltration and hypotony in the postoperative period. So obviously your thickness should be half to 2/3 of scleral thickness. And especially when you're using antimetabolites, you have to be very careful that you should not have thin flaps. And the shape could be any, it could be a triangular flap, it could be a rectangular flap, it could be a trapezoidal flap, but whenever you're doing a rectangular or a square flap, please remember the flaps, side flaps have to be parallel, while they are slanted for a triangular flap. However, what is important is do not cut right up till the limbus. Cut short of 1 to 2 millimeters of the limbus, except in the center, obviously you'll be doing more dissection. What is the advantage of this is that it gives you a more posterior flow and gives rise to a diffuser bleb. And then is the anterior paracentesis. While doing a paracentesis, remember it is not like a cataract surgeon. We do not go directly towards the lens, especially if it is a phakic eye. Your direction should be away from the lens and parallel to the plane of iris. And if you're planning to place an AC maintainer, then obviously you can go tangential, like in this photograph it has shown out here. Inner sclerostomy, obviously you have to have a block which could be 2 into 2 millimeters or even smaller than that sometimes, depending on if you're taking a rectangular flap. But what is important is make sharp cuts. You do not want any shelving or any tunnel type of your inner sclerostomy. Especially, you can either use a blade or you can use a punch. When you're using a punch, again, when you're punching, please take it vertically and then take perpendicular bites. You do not want any shelving, as I said. So this is what is being shown. So while taking a punch, take it vertically and then cut. Similarly, when you're using a blade, you can again take very vertical bites and then cut the rest with a blade or with a scissor, Vanna scissor. As regards to peripheral iridectomy, ensure that it is a broad base, and when you're pulling out the iris, there should be peaking of the pupil. So remember that, and you should be able to see the edges of the pupil all around. Otherwise, you'll create a sectoral iridectomy instead of peripheral iridectomy. So it should be such that it should not be large enough to cause diplopia to the patient in the postoperative. It should remain hidden under your upper lid, but it should be wider than the inner sclerostomy. For that, it is important that you, while cutting, you place your scissors parallel to the limbus. Then is a scleral flap closure. So what is the end result? What you want is a well-titrated, well-formed AC at the end of your procedure. So it is important either, nowadays again the trend has shifted towards using releasable sutures, or even the cause who has described a technique of adjustable sutures. And while tying a knot, you use slip knots for that because it helps you achieve a desired tension. So the next 2 videos will show you how to use releasable sutures. There are various techniques described. There is a Kohler's technique, there is so the technique, mattress sutures are there. You can take any of the techniques which you can use out here. What is important is while taking a bite through the cornea, it's like a mattress. And then when you're taking a bite through the sclera, it is important that you take 4 throws and titrate the tension out there and keep it tight. But it should be such that it is in the form of a loop which can be released anytime when you require it in the post-operative period. So taking a bite through the sclera first, going to the cornea, taking making a mattress out there, and then coming back onto the sclera, and then taking those 4 throws. Slip knot is just to guide you to have tension control over your tightness of your knot. So this is just a technique showing how to do and make a slip knot for a non-releasable suture. Just last slide. Kaur, as I've already told you, Kaur has described a technique where he has not used a releasable suture. He has used a adjustable technique where he uses specialized forceps, where again the throws are taken in the same manner. 4 throws are being taken and a loop is created. But then he has a special suture which is there, a special forceps which is there, which can actually help in removing that, adjusting that tension and releasing that tension of the knot in the post-operative period. Last step is obviously the conjunctival flap closure. What is important is that, especially if you've made a limbus-based flaps, and if you're operating in a child or in a case of juvenile glaucoma, in those cases, maybe you can prefer to use close both the tenons and the conjunctiva separately. But whatever type of closure you're using, whether a single closure or a separate layer closure, it is important the tenons should not pop out at any time. While for a phonics-based closure, it is important that you use round-bodied needles because you do not want any leaks occurring through your needle bites. However, when you're doing a corneal scleral anchoring, in those cases, probably you can use a spatulated needle. And what is, in the end, is what you require is a watertight closure. So that is mandatory. So, and that can be titrated using your paracentesis entry, which you have made in the beginning of your surgery.
Dr. Vinta, please wind up.
They're finished.
Thank you very much, Dr. Vinta, for this stepwise surgical performance. Can I request Dr. Jaslin, who will be talking about the newer aspect of trabeculectomy, applying amniotic membrane in after the glaucoma surgery, after the trabeculectomy.
And even after all these decades, there is still scope for improvement. The ideal bleb where we want the filtering bleb to be diffuse, low-lying, relatively avascular, and having a polycystic appearance eludes a lot of us, especially over a period of time. The glaucoma surgery has had modifications so that we can deal with the wound healing process that takes place after the trabeculectomy. So there has been the use of antimetabolites. The surgical steps have also been modified to a great extent, and also space occupying wound modulators like the Collgen implants have been used, primarily in a bid to have a bleb which has a long success period, a better predictability, a good IOP control, and avoid serious complications of bleb leak and thin cystic blebs in the long run. So one of the new modalities that is being used nowadays is the amniotic membrane. The membrane is available easily and has been used lately in wound modulation of trabeculectomy, primarily because the amniotic membrane is anti-inflammatory, anti-fibrogenic, anti-angiogenesis, antimicrobial, lacks immunogenicity, and is easily available. The amniotic membrane is being used to augment the wound healing process, both by being an anatomical barrier, whereby it is keeping potentially adhesive surfaces apart, as well as being a biological barrier, where it is down-regulating TGF-beta and suppressing the fibroblastic and macrophage responses. On the whole, it has been found that it has improved the appearance of blebs and improved the longevity of the bleb. It's available in either a dry or a wet form. Both are recorded to have been used in amniotic, in the trabeculectomy. These membranes have been tested for viral markers and are relatively inexpensive. It's easily incorporated in the routine surgical technique that the surgeon is using, and it does not really have much of a learning curve. So it's perfectly possible to use it both in limbus-based or phonics-based surgeries. The membrane is usually applied over the ocular surface after the scleral sutures have been applied, though in refractory glaucomas, or in repeat trabs, some people have also used it partly subscleral and partly subconjunctival. The watertight closure is recommended. We've used both the dry and the wet forms of the amniotic membrane and find that the wet form adheres better to the ocular surface and even in the post-operative period maintains better bleb appearance. On occasion, the dry form has been found to probably get rolled up, so the blebs were a little irregular or high. It can be done both as a primary procedure as well as in addition with mitomycin C. Anchoring sutures are usually not really required. When we look through the literature, we see that amniotic membrane has improved the success rate. In one of these studies which was done at Guru Nanak, it actually improved the absolute success rate from 60 to 80%. And though some other reviews show that the IOP control may not be markedly different between the whether we use Trab with MMC or Trab with MMC plus AMT, what it does make a difference in is that the architecture of the bleb is much better. In fact, a newer study has also shown the ultrasound biomicroscopy report of the blebs, and it has found that the percentage of diffusely elevated blebs is much better, and the overlying conjunctiva is healthier. On the whole, even fewer post-op interventions have been found. So in refractory glaucomas or in repeat, आपके वहाँ से इधर पे आ रहे हैं. So basically, when we have a refractory glaucoma, they recommend that this area of membrane cover should be larger, and one could combine using it both subsclerally and subconjunctivally. So in our center, we've been using the amniotic membrane along with mitomycin C to augment trabeculectomy, and we've done it for about 2 years now. A significant number of cases have been done, about 100. We took out about 30 that were primary open angle and as a primary surgery, which did not have any additional risk factors. And the pre-op IOP was on an average, the mean was 27.76 plus minus 6.9. And the post-op at 1 month was 11.9 plus minus 4.8. And at 1 year, it was 15.28 plus minus 4.25. 4 of these were on 1 anti-glaucoma medications at 6 months, and 2 of them were on 2 medications at 1 year. We had an incidence of shallow anterior chamber in 2 patients in the first week, which resolved on conservative management within a week. And 1 case had hypotony maculopathy, which also recovered in 6 weeks with good visual prognosis. So it does have promising trend in case in patients of trabeculectomy, where AMT can be used as an additional wound modulator in addition to the use of mitomycin C. We have not really done it in patients without mitomycin C, and it is a tool that can be used as an armamentarium. Thank you.
Thank you, Dr. Jocelyn, for saving time, but we are so disturbed because the audiovisual didn't work, and we missed a lot of audiovisual things for you. Thank you very much. Can I?
Now, the next speaker for the talk is Dr. Shali Mohan. She'll be talking about collagen matrix implant augmentation in the traps.
अभी आया
Thank you. Thank you, Chair. Good afternoon, everyone. At the outset, I would thank Dr. J.C. Das, sir, for giving me this opportunity to share my views about trabeculectomy with Ologen. I don't have any financial disclosures. So, we know that trabeculectomy is the gold standard surgery because gives better diurnal control and effective in disease progression with good success rate. But then we do have problems with trabeculectomy, and the most important cause of trabeculectomy failure is subconjunctival and subscleral fibrosis. So these are the various problems we are having with trabeculectomy surgery. Now, not just this, there are certain of the cases where actually we don't get the desired results, may it be complicated glaucomas, post-PK glaucomas, uveitic glaucomas, and so on and so forth. So, we are talking about various modifications to augment this trabeculectomy surgery. And regarding wound healing modulations, there are variety of factors. Just now we heard two talks, one on mitomycin C and another one on amniotic membrane. Nowadays, mitomycin C actually gives very good results, and majority of glaucoma specialists, they are using mitomycin C in different dosage and different duration depending on the case, and it has definitely revolutionized the treatment. But then there are definitely complications associated with usage of mitomycin C also, and we have seen thin wall cystic blebs, blebitis happening with usage of mitomycin C, hypotonic maculopathy, scleral melts, and sometimes suprachoroidal hemorrhage or choroidal effusions. Now, because of these problems, the device which has recently come up is collagen matrix implant, which is Ologen, which is basically to increase the success rate by reducing the fibrosis. It is anticipated that it biodegrades within 90 days and is implanted over the scleral flap. Now, this Ologen is basically a porous structure where pore diameters are between 10 to 300 microns, which comprises of ethylocollagen and glycosamine glycans. It is available in two dimensions in our country, 6 into 2 and 12 into 1 millimeter. Now, what does this achieves? The goal this achieves is that it gives a physiological environment for fibroblastic cells to grow into the porous structure, which maintains and gives a stiffness to the bleb. It also preserves and functions as a reservoir without collapse during the period of wound contraction. And it also provides, when it absorbs aqueous, it sort of provides a physical weight onto the scleral flap and therefore prevents shallow anterior chamber in post-operative period. So what we do, we complete our trabeculectomy surgery as we routinely do all our surgeries, and then keep this Ologen matrix implant just behind the scleral flap. And then important thing is to ensure a watertight closure. Now here we can see that the thickness of the bleb is uniform avascular bleb, and we don't get thin walled blebs as we get with mitomycin C. So just an animation to show that how do we implant this Ologen. After suturing your scleral flap, we put one releasable suture and one non-releasable dip. You can modify your own technique, and then this Ologen is implanted onto the scleral flap, and then you get the watertight closure. So in fact, you can divide this Ologen into two halves and can implant onto the surface. It also gives equally good results if it is divided into two portions. The important thing is that we don't want any wound leakage in the post-operative period, and we don't want this to rest onto the scleral flap and doesn't avoid the aqueous drainage. So there are various systemic reviews and meta-analysis, and they have seen that the effect of Ologen and mitomycin C with trabeculectomy is comparable in reducing the IOP, reducing the intraocular pressure in the patients, in reducing the number of anti-glaucoma medications, and in improving the success rate. Now the various studies are available, and at our center also we have done a comparative analysis of both the groups, in Ologen group and mitomycin C group, and what we have found that it is good in reducing the intraocular pressure. There is some advantage of Ologen over mitomycin C, that the shallowness of chamber is less, the bleb is more thick wall and diffuse, and there are less incidence of bleb leakage also. Now, this is another Indian study to say that Ologen is effective and equivalent to mitomycin C. Now, there are other things which are happening with Ologen, like people are using it for patch graft also to cover the tube of the Ahmed glaucoma valve, and they are also doing bleb needling with the help of this implant. So the question arises to our mind is, if it is equivalent to mitomycin C, why actually we are targeting why we are discussing about this new device? Now, the indications are primarily in the patients who are having thin sclera, where we don't want to apply mitomycin C, which can further cause thinning, staphylomatous eye, myopic eye, and if there is too much risk of infection. So, in these cases, we do get added advantages of Ologen over mitomycin C. So, to conclude, I will say it is a viable alternative. It is comparable and indicated where anti-metabolites are contraindicated, because it causes less of thin wall cystic bleb. And moreover, we don't need to dispose of the sponges as we need to do it for mitomycin C. Thank you so much for your kind attention.
How many cases you have done so far, Dr. Salini?
31, sir, with Ologen. 30.
And what is the success rate and follow-up period?
Sir, follow-up is around 9 months now, and success rate is around 85%. The patients are doing good around 85%.
Okay, because we have been doing Ologen for a very long time, and somehow we are not very satisfied in doing the Ologen. In fact, it causes more of shrinkage sometimes. The blade becomes flat very often. So that's why practically we have stopped doing it. And in case you get the good results, we might revive this surgery again. Why not?
Sir, what we have realized that otherwise mitomycin C is an excellent agent to be used with trabeculectomy, and we need not to modify our technique except in few selected patients where we are having thinned out sclera or something like that. Otherwise, trab with mitomycin C is still a gold standard technique.
Thank you, Dr. Shalini. Now I'll invite upon Dr. Das to talk about changing patterns in tube
लगाना
surgery.
भाई कहाँ है? Okay. Thank you, Dr. Vinita. And see, why the change? Why want to change a surgery if it's giving us the best results? The success rate is very high, complication rate is practically nil, we need not have to change it. But all the years from 68 onwards, we have seen that the particular procedure, whether this is only trabeculectomy, doesn't work well. We changed over to mitomycin C and 5-fluorouracil. Did very well, but with more of complications, we are not satisfied. So what we want to do is that the success rate should increase and the complications should decrease. We should adopt a procedure which will be safe enough with a great results in it. I will quote only two. There are hundreds of articles under that, but I will quote recent 2 articles where the 10 years follow-up. The success rate is 73%, but the complication rate is 56%. See the complication rate in 10 years' time in the tube surgery. We are talking about the tube surgery now. In a 3 years follow-up study, you can see that the success rate is 67%, but yet the failure rate is at 33%, with very severe complications of 22% in 3 years' time. That means we need to change our procedures, change in the form of modification in the material itself, in the tube, or its design itself, or the procedural change, whether you stick to the same trabecular meshwork or explore the other possibility of drainage. Coming to the tubes, there are 3 common varieties of tube used at the time, but this is different models of AGB. The first change was to change from the polypropylene body to a silicon body. And there are changes from the adult models, also the pediatric models. There are also changes to have another separate draining area with additional attachment, or it is also a change in the form of draining to the pars plana by the pars plana clips, or it is the tube extenders. So there are various modifications in AGVs, starting from its material from polypropylene to silicon, and as well as all the models. The same type of changes in Vervox was also made. The only thing, Vervox has got a barium impregnated silicon body which is opaque in X-rays, so it is easily located during the follow-up time. If it is necessary, you do the X-ray and find out where the valve is. Starting from its 250 square millimeter to 300 square meter, 350 square meter of different types. So, and lately, the still larger body with the Eagle Vision implant was introduced with a 365 millimeter square body with little change in the surface area in the form of ridge. And there is also pars plana clips in the form of Hoffman elbows, so you can put it in the pars plana region without coming to the limbal area. And there are also strip cords which can be stent can be put to the interluminal portion to reduce the flow, overflow, and it can be gradually reduced or gradually removed to resume the normal flow. Molten in its place has also changed its modifications in the form of the initial body was 137 square millimeter, it's changed to 175 square millimeters, and with the double plate also, and moreover it has got a ridge on the central area and around the rim, so that it causes little restriction in the flow over its surface. Apart from the designs and materials, there are modifications in the existing procedure that some people put the tubes, maybe 6 to 7 millimeters, they put a 23 gauge needle and a tunnel and enter the antechamber. Through the tunnel, they put the tube and enter the antechamber. And now it has been a common practice to use scleral or collagen the patch grafts, scleral patch grafts. Even the amniotic membrane or in the pericardium can be used. And many people have started using mitomycins in the posterior part where the valve body is present. And the anti-proliferative biodegradable drugs has also been used for increasing the flow rate. There is little change in its pattern. In case you cannot put the HVs in the superolateral quadrant, you can put it in the inferior quadrant, and it can be same way, can be effective. And these slides have been borrowed from Dr. Hirsch, and it can still place the tube in the pars plana region in cases of where you need a vitrectomy, and you do a vitrectomy and don't have conjunctiva available much, then you can also put in the pars plana after doing a good vitrectomy. Apart from the draining to the subconjunctival space, there may be a subconjunctival drainage procedures which can utilize the smaller tubes like express mini shunt. It was used for a long time, no way working. Collagen is still in the process of evaluation. Gen implant, which has been introduced lately, is supposed to be an internal procedure. You have to come from the opposite side and go to the antechamber angle and then put it into the subconjunctival space. And it is little cumbersome and needs little, learning curve. And to get rid of that, we have got the in-focus micro shunts, which is the AIOC2020 procedure, dissect in the conjunctiva and put it in the subconjunctival space. The results are still not very comfortable. They have changed the model from 220 by say 90 to it is 90 by the 45. The inner core is only 45 macrons now. It was 120 macrons earlier. I don't know why they changed it, but American FDA approved only 45 millimeter bore gen implants. The second modality is to see that the supracranial drainage is taken care of, or supracranial drainage is another mode of drainage, and gold micro-shunt stents have been really for use quite some time, not very effective. Cypass micro-shunts is again been used, but the endothelial count is very less with this kind of endothelial damage. We do not know why, but later they found out that the rings, the more the rings are projected into the antechamber, the more is the endothelial damage. That's why they have changed it and they put it into the deep into the suprachoroidal space. iStent Supra is another attempt like the Cypass, and microjet implants are there. And now there is another tendency that you revive the physiological pathways, that means attacking only the trabecular meshwork. Canaloplasty is still not very commonly used, takes a lot of learning curve. iStent, which is again put in the trabecular meshwork. So it is from the 6 o'clock position, come to the 12 o'clock and put it. iStent injects is also another procedure which is coming up, and hydrous microstent and trabectome hook, hooks double hook, and I think Dr. Parul Soni will be talking about these procedures more. What I want to say that there is a tendency for the tube surgery to evolve from a very selective indigenous procedure, selective indications, to a primary procedure, and the glaucoma drainage practice, the surgical practice pattern appears to be shifting away from the trabeculectomy, but with mitomycin C and with tube shunt. But this is with a caution. Efficacy and safety do not go hand in hand. Irrespective of whatever procedure you do, when the efficacy increases, the rate of complications also increases. That is what is occurring so far. MIGS surgeries are not as effective as the trabeculectomy with mitomycin C or the tube shunts. Moreover, no procedure can be judged as superior. That is the final word, that the no procedure can be judged as superior to the other, because all the studies available in the literature are based on the different study populations, different parameters, no consensus study. So all the studies are available favoring tube or discarding trabeculectomy with mitomycin C doesn't stand true at the moment. Thank you very much.
Thank you, sir. We'll take questions, or if any questions are there, we can still take them till I invite the next speaker, who's Dr. Parul Soni. She'll be talking about MIGS. Can they sneak in?
No.
Let's listen to her, and then sir can probably say definitely no after that again.
Good afternoon, everybody. And I think in this course we have been seeing that how are we trying to can you hear me? I think the mic is on. Yeah. So we are just, thank you Professor Das and thank you AIOS for having me here. Now at the outset I would like to say that I'm talking about MIGS, but I have not implanted any of these devices. So it's just basically what I have gathered from the literature and from different articles I'll be presenting here. So we all know that glaucoma surgery, trabeculectomy is still considered as gold standard, but as we see that there are a lot of early and late post-operative complications, and therefore the focus is shifting towards improvising the technique and maybe towards non-penetrating glaucoma surgery. What MIGS actually mean is minimally invasive glaucoma surgery, which is one of the most exciting recent developments in the treatment of glaucoma. The MIGS brings the advantage of the newer option for those patients who do not meet the criteria for a routine trabeculectomy. It is less invasive than trabeculectomy and has the ease of combining it with the routine cataract surgery. It uses an ab interno approach, therefore leaves the conjunctiva intact for a potential later trabeculectomy or a non-penetrating surgery. So the cardinal features of MIGS include a ab interno or a microincisional approach, minimal trauma or disruption of a normal anatomy and physiology of the angle, demonstrable and reliable intraocular pressure lowering with an extremely high safety profile, and a rapid post-operative recovery with minimal need for follow-up. Now, the MIGS surgeries can be divided into basically 3 techniques, as Dr. J.C. Das was also mentioning. So there are techniques which cater to the normal trabecular on the routine trabecular meshwork by altering or by reducing the resistance of trabecular. It's not showing on the screen, no? Okay. Anyways, so the first category are the techniques which bypass the trabecular meshwork resistance. The second subgroup is the implants which increase the uveoscleral outflow via suprachoroidal pathway. And the third subgroup of MIGS surgeries create a subconjunctival drainage pathway which is little different from a routine trabeculectomy. So in the first group, the techniques which bypass the trabecular meshwork, we have different techniques like the trabectome, the GATT, canaloplasty. I'll be talking about all these techniques in a little bit of details shortly. So the first subgroup in which we bypass the trabecular meshwork resistance is either you can excise a small part of trabecular meshwork using a trabectome or a Kohut blade. So a small sector of trabecular meshwork is excised and the aqueous starts to drain directly from the anterior chamber into the Schlemm's canal. Now these procedures are FDA approved and have very lower complication rate, but they have very moderate kind of intraocular pressure lowering. So the pressures are lowered usually up to mid-teens only. Now the second subcategory is again bypassing the trabecular meshwork resistance by dilating the Schlemm's canal, which is done in a 360-degree manner using either a microcatheter which is put in the Schlemm's canal 360-degree, or you can use a OVD device, or you can also use a nylon based catheter like in Trab 360-degree. So all around the Schlemm's canal is cannulated and either the wire is pulled out to create a 360-degree trabeculotomy, or you dilate the Schlemm's canal. Now in the third subgroup of procedures, again you try to bypass the trabecular meshwork resistance by placing a small implant, one end of which lies in the anterior chamber, the other end lies in the Schlemm's canal. Now iStent is one of the most popular one, which is again FDA approved, and it's the smallest implantable device. So this is how it looks like. So you can place more than one iStent in a patient while you're doing phacoemulsification, so you can easily combine it with the phacoemulsification. The other device is Hydrus microstent, which again has fenestrations which drain the aqueous from the anterior chamber into the Schlemm's canal. The second subset of procedures are those which increase the uveoscleral or the suprachoroidal outflow. So in these, the two common ones are the SciPass and the iStent Supra. As Dr. Das was mentioning, that the SciPass has three projections which are put ab interno and they lie into the anterior chamber, and from here with the vacuum effect the aqueous moves from anterior chamber into the suprachoroidal space. iStent Supra is again the most popular one of these and which has been there for a couple of years now. The third category is the drainage which happens into the subconjunctival space. It is little different from routine trabeculectomy. The blebs are little low lying and it's an ab interno approach. So you can have what you call a Zen implant, which is implanted during cataract surgery, or it can be done without cataract surgery also, using a ab interno approach, and the implant is placed from the angle into the subconjunctival space like this. The in focus microshunt is placed ab externo, so you create a conjunctival flap and then you implant it into the anterior chamber. The another subgroup of procedures which is gaining popularity is endoscopic cytophotocoagulation. Now this is direct photocoagulation of ciliary process under visualization using an endoscope which delivers 810 nanometers of diode laser with xenon light source and a helium neon aiming beam. So what you can see, up to 70 to 80 degrees of ciliary processes are visible and they can be coagulated under direct visualization. If you use a thicker probe, you can access a bigger area. Though the indications are still in evolution, but it can be used with phacoemulsification for treatment of mild to moderate glaucomas. It can be used in plateau iris syndrome, and it can also be used to augment the effect of GDD and in patients who are not very good candidates for filtering surgeries. Now we have so many options to choose from, so it's a difficult decision that which is better out of the lot. So let's see each one of them. So that the mechanisms or the implants which are basically targeting the trabecular outflow are limited by the episcleral venous pressure. So these implants, the surgeries like trabectome, the eye stents, they are limited by the episcleral venous pressure, so they are not very efficacious. The MIGS which create a subconjunctival drainage, like we have the Zen implant and the in-focus microshunt, again they result in formation of bleb, so they can have complications which are little similar to trabeculectomy, that's the bleb related complications and hypotony. So the third subgroup of procedure, that's the suprachoroidal implants, have what you call a suprachoroidal advantage. So the intraocular pressure lowering is not limited by the episcleral venous pressure, and because they do not result in formation of a bleb, so they don't have complications like hypotony or bleb related infection and all. However, these suprachoroidal procedures are more invasive and there is theoretical risk of suprachoroidal hemorrhage. So the popular ones out of all these are eye stent, the eye stent supra, the Zen implant which is marketed by Ologen, and the ECP. Now when we look at the literature, there are multiple studies which have come up and they have shown that these MIGS surgeries have lower risk with a very high safety profile. However, the most important limitation is that they offer only a moderate intraocular pressure lowering. There are a couple of studies which have shown that eye stent and eye stent supra can also be used in patients who have had earlier trabeculectomy or refractive glaucomas, and they have follow-up of almost 4 years showing a good intraocular pressure lowering with decrease in the number of medications that patients require. Again, there are a couple of RCTs which have shown that patients who have mild to moderate glaucoma and are undergoing phacoemulsification, combining an eye stent or a hydrus or a sci-pass shunt gives an additional advantage of intraocular pressure lowering so that the patient can be pulled off glaucoma medication. And the visual recovery and the safety profile remains almost at par as the phacoemulsification alone. So this is a good option, especially when you do not require a very low target intraocular pressure. Now let's compare the MIGS with the gold standard trabeculectomy. As Sir was saying, whenever we try to decrease the complication rate, the efficacy also goes down. Or you can say if the success rate is good, the complication rate are also high. So there are studies which have shown that trabectome or MIGS surgeries have lesser complication rate. If you compare it something like 4.3 as compared to 35% of complication rate with trabeculectomy. However, the success rate is also much inferior as compared to trabeculectomy, a 22 versus a 76% with routine trabeculectomy. Therefore, MIGS is not a very good substitute for trabeculectomy except for certain subset of patients. So when we compare MIGS with trabeculectomy, MIGS surgeries are very expensive, they are less effective, therefore not surgery of choice for advanced glaucoma. They have learning curve and we have variety of options to choose from, and we do not have long-term track record. So despite all the articles and papers, when there is lack of consensus, we do not know which is the best MIGS device to be used in a particular patient, and affordability and insurance is also a problem. So I would like to conclude by saying that in current practice, I think where MIGS could fit in would be that we should opt for a stepwise approach, that only mild to moderate cases of glaucoma, especially elderly patients or non-compliant, can be considered for MIGS. Thank you for your kind attention.
Thank you, Dr. Parul, for the honest opinion. Can I request Dr. Susmita now, in spite of her not so well today, she has agreed to give this talk. Thank you, Dr. Susmita.
Thank you, sir. At the outset, Professor Das and Vinita and AIOS. So we are going beyond the pressure. And for all of us who deal with children, we know that our job doesn't finish there because we have a lifetime to handhold and let them see better. So we know that it's a potentially blinding condition, and therefore our job doesn't end with IOP control in glaucoma or settling the retina if you're a VR surgeon or clearing the cornea if you're a cornea surgeon. Ultimately, you need to ensure vision. And preserving their long-term vision is the real challenge. So this neonate with CTT, with pressures control, your job is not done if you stop here. You have to push your cornea colleagues to do a transplant and then push them and hold their hands because they're going to come back to you with post-PK glaucoma maybe. So this is a desirable outcome. This is a 2-day-old, malnourished, underweight infant with bilateral severe PCG. So we admitted him, and he underwent pediatric consults. He had to actually have parenteral feeding because he was so underweight that he wouldn't even suckle. But anyway, we did the bilateral CTT whenever we could. It's clearer cornea 2 months down. He's at least started sucking a milk bottle now, and he's under pediatric care for systemic malnourishment. He was in hospital for a good 6 weeks or so. And at 18 months, you finally have this robust baby with a clear cornea, a healthy, normal child, right eye larger but not significantly myopic as yet, but under close watch for ocular deviation and amblyopia management. So your job doesn't end with just doing a CTT for a newborn baby that comes to you. Some stories can be much longer. So this 3-day-old PCG, for instance, who's come with left eye trab with trab at 5 days old and right eye at 1 month, and a persistent corneal scar in spite of pressure control. So you push for OPK, and once you push for the OPK, they come back to you with severe post-PK glaucoma, and then you put in the ADI. And 3 years on, the pressures are 14 on timolol, active patching in the right eye, and best corrected vision in this eye now 624, but we hope to get it down because she's just 3 years old as yet. Sometimes they come to us too late, and Parul and Shalini would empathize with this. The 16-year-old girl, your heart sinks because now the parents actually sometimes come and say, ab iski shaadi karni hai. I mean, you want to get her married now, and you know, what were you doing all this while? But there's no point in saying that. The right eye is atrophic. Don't write her off. Give her some hope. So she came to us with pressures of 30, vision of hand motions. The ultrasound showed a totally cupped disc, but we did go ahead with the trab with MMC, push the cornea service to do the OPK. She's now vision, counting fingers, 3 meters, and has seen more than she's ever done in her life before. So in spite of the challenges, if we don't give up, we can give them some hope. Sometimes an OPK is just not possible. There are constraints of tissue, there are constraints of reluctant pediatric cornea surgeons who don't want to do it because of a congenital limbal stem cell deficiency which happens in congenital glaucoma because of the severe stretching. So this PCG, 6 months old, severely photophobic. You can see she's hardly opening her eyes when she came to us here. Bilateral trab with trab done. The steamy cornea cleared, but the central scar remained. So she had severe congenital limbal stem cell deficiency also. So all we did was went ahead with an optical iridotomy. So we did do an optical iridectomies very, very often nowadays. And at least she's seeing, she's enrolled in school. Her vision though is 636 and 660, but we hope to handhold her as she's growing up. So even if the IOP is controlled, the cornea is clear, the disc is healthy, is your job done? So if you see this kid, for instance, operated at 9 months, and for some strange reason, because the cornea cleared and he was fine, he was lost to follow-up. And one fine day when he's about 4 years old, he came back to us, 10 pressures, cornea clear, disc healthy. Is your job done? But then you do a refraction and the myopia is like -21 in this eye, and these are the kind of glasses he was prescribed. So no child is going to be able to see like that. So we are fortunate that we have Professor Jagatram who allows us to push him, and this child actually, underwent clear corneal extraction for this, and actually he had to put in a -4 diopter. So on active patching with a near emmetropic eye now, even though the cornea is so large, you can see the glasses. These are glasses only for near in the right eye. His best corrected vision now is 612 on the active patching in the left eye. So your job really doesn't finish anywhere until you push and push for your children to see well, and that's what you're here for. Sometimes you need to make these clinical decisions, and ancillary testing is important. So you had this baby with a right corneal scar and a Peters abnormality basically. But there was a right central scar, and if you looked at this UBM, you know that this anterior segment is all right. So we've done an optical iridectomy there, and someday we'll push for an optical PK as well, but tiding over the vision till then. but the left eye, you can see that part of the lens is also there. So sometimes it's also prudent to know when to stop. So we're not going to touch this eye at all because this is not going to give you anything. Concentrate on an eye which has vision potential and take on from there. Remember, after having said all this, at the end of the day, the vision and eye and everything, the babies have a life. So this 2-day-old baby, again, with this clear thing in the middle, looked like a Peters, left was PCG, but to our horror, the UBM showed the Descemet's defect was so large that this lens was actually stuck and sequestered in the cornea. So then when you have something like that, we did try and get his lensectomy out. He did undergo surgery, but we landed up in an unsightly blind eye in the right, but the left eye cleared well with the CTT. So then you counsel the parents. We've had this enucleated and put in a prosthesis. So remember, this child doesn't need to go to school like this. You can make the child go to school like this. Only the parents and the child knows that there is no eye in the right eye. But this is the same child, so you need to go further beyond the eye also at times. Again, more than the IOP, this 4-month-old baby with no pupil in the left eye. You can see this eye has no pupil. It's actually a condition called achoria, where there is no pupil formed. It's imperforate. And the IOP is 26 with no visible angle structures. And we saw on the UBM that this was actually adhered to the lens. So when you have something like that, the better thing to do is prudence. If you're going to go right in the center, you're going to touch the lens, have a cataract, and then you take out a lens in a growing eye, you're in deep trouble. So all we did was an eccentric pupilloplasty and active patching and have the vision up to 636 by now. The cornea is clear after the goniotomy. The IOP is 18, so we'll just handhold and carry on with there. Just one caveat, is all newborn glaucoma really PCG? We had this problem of why the neonatal glaucoma behaves so differently from the infantile ones, and to our horror, we saw this was a turning point really in our thinking of childhood glaucoma, because we actually, when we did a UBM, we saw a nuclear cataract. And when we started testing them, then they were rubella. So we've done a lot of rubella testing for neonatal glaucoma as yet. And one thing that we learned is that if you have a small eye with glaucoma, then think of rubella. And why that's important is not just academically that you pat yourself on the back and say, I've diagnosed rubella, because these children could be deaf, they could have cardiac defects, which we would never look for if we don't think of rubella. So think of intraocular infections as well when you're dealing with neonatal glaucoma, and not just the pressure. So the cornea didn't clear in the rubella babies. These are neonates who did not have rubella, and you see how their cornea clears. But if you have rubella keratopathy, the corneas remain white. So that's another thing to keep in mind. If your corneas don't clear at all, despite pressure control, then you're probably dealing with a rubella cataract. So to summarize, clinical examination is the hallmark in the management, and so much is unknown. Ensuring good vision is a goal, not just IOP control, and we need to hold these children's hands lifelong. Thank you.
Thank you, Dr. Susmita, for the excellent talk. And there is absolutely no time. I'm sorry, we are handing over to the next session. And I thank all the speakers for their excellent talks. Thank you very much.